Good morning. My name is Shannon Sorensen. I am the CEO of Brown County Hospital, a critical access hospital located in north central Nebraska. I would like to thank Chairman Brady, Ranking Member McDermott, and the members of the House Ways and Means Subcommittee on Health for holding this hearing. Approximately 1 in 6 Americans live in rural areas and depend on the hospital in their communities. We are exactly one of those facilities. Not only does our location, being over 150 miles from the nearest tertiary facility, affect us, our patient mix, being over 70% Medicare, also makes us more reliant on public programs. Changes, such as the 96-hour rule, often have significant and problematic consequences for rural providers. Due to the great support of our local community, compared to many of my peers, our hospital's financial situation is stable, but we are especially vulnerable to Medicare and Medicaid payment cuts. We are the communities and hospitals that most need your help. The 96-hour rule is especially burdensome in our day-to-day mission of providing health care in our communities. From the creation of the CAW designation until late 2013, an annual average of 96-hour stays allowed CAW's flexibility within the regulatory framework set up for the designation. The new policy of strict enforcement of a per-stay 96-hour cap creates unnecessary red tape. Not only does it potentially limit access to health care by forcing rural beneficiaries to travel farther for treatment, it may deter them from seeking necessary care, inconvenience patients, and add travel costs to Medicare. It impedes rural providers in their ability to care for their patients. Having to focus on regulatory burdens interferes with the best judgment of physicians and other health care providers, placing them in a position where our providers are constantly making regulatory decisions to dictate the medical decisions they need to make. The 96-hour condition of payment leaves no room for needed change in the medical care plan if treatment does not go as anticipated. It's also important to note that while we must maintain an annual average length of stay of 96 hours, we offer some critical medical services that have standard lengths of stay greater than 96 hours. Enforcing the condition of payment will force us to eliminate these 96-hour-plus services and cause financial pressures that will severely affect our ability to operate. These are important services in our community and allow patients to get needed services and recover around their family and friends. CAWs in Nebraska and across the country support the Critical Access Hospital Relief Act, which would remove the 96-hour condition of payment. I'm especially pleased to thank my representative, Congressman Smith, for introducing the important legislation. Rural facilities and providers face many challenges without the heavy hand of government. We must be given the flexibility to provide affordable and efficient health care. Another burdensome regulation is the expansion of mandatory direct physician supervision. We simply do not have the manpower and resources to abide by these arbitrary regulations. Our highly trained, licensed personnel are not able to practice at the highest level of their scope with this regulation. For 2015 and beyond, the agency requires a minimum of direct supervision for all outpatient therapeutic services furnished in our critical access hospital, unless it's on the list of services that may be furnished under general supervision or is designated as non-surgical extended duration therapeutic service. We're deeply disappointed that CMS did not heed concerns that this policy will be difficult to implement, will reduce access, and is clinically unnecessary. CAWs in small rural hospitals support the adoption of a default standard of general supervision, consistent definition of direct supervision, and prohibiting enforcement of CMS's retroactive reinterpretation back to 2001. H.R. 170 delays the unnecessary and burdensome physician supervision regulations and requires CMS to study their impact. We already face many unique challenges, such as providing quality care with more limited resources, satisfying complicated administrative requirements with a smaller staff, complying with numerous federal regulations which limit the discretion of highly trained providers, and now we're forced where in the building we must be located to render these services. Our community has one full-time primary care physician who is supported by 2 mid-level providers. With some of the regulatory burdens we face, such as requiring only a physician to oversee cardiac rehab, or only a physician being able to order durable medical equipment, home health, or hospice services, anytime our lone physician is not on our campus, takes a vacation, or attends continuing education, significant patient needs have to wait. Our very capable mid-levels are able to provide the needed services in our emergency room and throughout the hospital. It makes no sense to prevent them from being able to do the same for cardiac rehabilitation, outpatient therapeutic services, or other necessary services. Medicare provides vital funding for many rural payment programs, including critical access hospitals. This subcommittee in Congress has the power to ensure Americans living in rural America who depend on the hospital will have access to appropriate care. Again, thank you, Congressman Smith, for introducing H.R. 169. We appreciate the subcommittee's interest in the matter and urge it and the Congress to support much-needed legislation. Thank you for your time and listening to our impact.